the Fetal Medicine Forum podcast. Today, we're dedicating an entire clinical session to one of the most challenging and high-risk areas in obstetrics: assessing and managing the small fetus, specifically small for gestational age and fetal growth restriction. Adopting precise, evidence-based frameworks is essential for improving perinatal outcomes. I'm joined by our expert to guide us through the latest criteria and surveillance protocols, drawing from FIGO, ISUOG, and the RCOG 2024 guidance.
It's a pleasure to be here. The foundation of accurate management starts with robust assessment, and that's what we aim to clarify today.
Let's begin with the initial steps in any assessment. What are the two non-negotiable starting points?
The two foundational steps are risk stratification and absolutely accurate gestational age confirmation. For risk stratification, we review the patient's medical records, prior obstetric history, and current pregnancy to determine if she's high or low risk. High-risk patients go straight to enhanced surveillance, while low-risk continue routine follow-up, unless clinical signs emerge. Gestational age confirmation must be established as early as possible. The most accurate methods are the embryo transfer date in assisted reproductive technology, or crown rump length measurement in the first trimester, with a margin of error of around 5 days.
So, we don't rely on the last menstrual period alone?
Correct. LMP alone is unreliable due to factors like hormonal contraception, irregular ovulation, or recall bias. We prioritize CRL or embryo transfer dates. After the CRL window, head circumference and femur length are acceptable up to 24 weeks.
And what about fundal height?
Once gestational age is fixed, symphysis fundal height is useful up to 24 weeks, and again, from 29 weeks onward. A discrepancy over 3 centimeters between SFH and expected gestation is a red flag for fetal growth restriction, requiring ultrasound assessment.
You also mentioned growth charts.
Yes, customized growth charts are critical. Standard charts often miss ethnic and regional variations. Customized charts are among the most effective methods for detecting small for gestational age.
Let's move to surveillance planning, especially for the high-risk group you mentioned.
In high-risk patients, we establish the third trimester surveillance plan early. Uterine artery Doppler is performed between 18 and 24 weeks. If normal, we follow up with Dopplers every 2 weeks between 32 and 36 weeks. If abnormal, surveillance begins earlier, with tighter scan intervals after 24-28 weeks.
What's the guideline for growth scan frequency?
Serial ultrasound growth assessments should never be less than 2 weeks apart. Physiologically, meaningful fetal growth changes cannot be observed in shorter intervals, risking misinterpretation. The latest RCOG 2024 guidance recommends growth assessment every 2 weeks for suspected or confirmed fetal growth restriction.
Let's be precise about the diagnostic criteria for fetal growth restriction.
Fetal growth restriction is diagnosed if estimated fetal weight or abdominal circumference is below the 3rd percentile, regardless of Doppler findings. Alternatively, if these measurements are between the 3rd and 10th percentile, there must be at least one marker of placental dysfunction, like abnormal uterine or umbilical artery Doppler. Finally, a drop in growth trajectory by at least 50 percentiles, even if remaining above the 10th percentile, is concerning for evolving fetal growth restriction. Using this precise language helps avoid vague terms that can delay intervention.
Differentiating between early onset and late onset fetal growth restriction is essential, as management differs. Can you outline the differences?
Early onset fetal growth restriction is diagnosed before 32 weeks. First, exclude structural or chromosomal abnormalities. This requires a detailed anatomical survey and possible genetic assessment. The diagnostic criteria are estimated fetal weight or abdominal circumference below the 3rd percentile or between the 3rd and 10th percentile with abnormal Doppler findings. Late onset fetal growth restriction is detected at or beyond 32 weeks. Again, exclude fetal anomalies first. The diagnosis requires either an estimated fetal weight or abdominal circumference below the 3rd percentile or 2 out of 3 parameters, measurements between the 3rd and 10th percentile, a fall in growth by more than 50 centiles, or evidence of placental dysfunction on Doppler, such as an abnormal cerebroplacental ratio or elevated umbilical artery PI.
You mentioned cerebroplacental ratio. Is that preferred over umbilicocerebral ratio?
Yes, we use cerebroplacental ratio for guideline alignment. The evidence base is stronger, and no clear advantage exists for umbilicocerebral ratio. After diagnosis, revisit the first trimester NT scan and second trimester anomaly scan to ensure no subtle structural abnormalities were missed. For early fetal growth restriction, long bone measurements are key. If the femur or humerus length is over 2 standard deviations below the mean or under the 5th percentile, consider genetic syndromes and refer for evaluation. We measure head circumference, biparietal diameter, abdominal circumference, and femur length to calculate estimated fetal weight. Abdominal circumference alone is a strong independent marker for growth assessment in fetal growth restriction.
Doppler is central to surveillance. Can you break down which vessels to assess and when?
Absolutely. Umbilical artery Doppler is our primary tool for assessing placental resistance. It's especially informative in early-onset fetal growth restriction, guiding both monitoring and timing of delivery. But in late-onset cases, the umbilical artery Doppler may appear normal even in compromised fetuses, so interpretation must be cautious. Uterine artery Doppler is mainly a screening tool, best used between 18 and 24 weeks in high-risk pregnancies. It helps stratify risk and predict placental insufficiency, but isn't useful for serial monitoring in the 3rd trimester. Middle cerebral artery Doppler and the cerebroplacental ratio allow us to detect brain-sparing physiology and evolving hypoxia, particularly valuable in late-onset fetal growth restriction. However, MCA or CPR findings should never be used alone to determine delivery timing. Always interpret them in the full clinical context. Ductus venosus Doppler detects cardiac decompensation and impending acidemia, most valuable in early-onset fetal growth restriction. When abnormal, it's a trigger for delivery per truffle protocol. In late-onset cases, it's less useful, as cardiac compromise is rare before other Doppler changes.
Beyond Doppler, what about amniotic fluid, biophysical profile, and cardiotocography?
These are key adjuncts. We typically use the deep vertical pocket for amniotic fluid to reduce overdiagnosis of oligohydramnios. Oligohydramnios with fetal growth restriction increases stillbirth risk, while isolated oligohydramnios is concerning but not always predictive of poor outcome. Polyhydramnios should trigger a morphology review and genetic evaluation. The biophysical profile is best as part of a surveillance package, not a standalone decision tool. Cardiotocography is valuable when combined with Doppler and other findings. Key red flags are reduced short-term variability and repetitive decelerations, both of which suggest acidemia and may indicate the need for delivery.
Before we get to delivery, which non-placental causes should always be in the differential diagnosis?
Always reassess for structural anomalies. Consider genetic syndromes when the baby is small with polyhydramnios and normal Dopplers, and screen for infections such as CMV, toxoplasma, rubella, and HSV where indicated.
What is the steroid and magnesium sulfate protocol in fetal growth restriction?
Antenatal corticosteroids are given when delivery is likely within 17 days before 34 weeks, per preterm protocols. You may see a short-lived improvement in Doppler indices after steroids, but it's false reassurance, hence continue enhanced monitoring. Magnesium sulfate is advised for neuroprotection in imminent preterm birth, but there is no unique fetal growth restriction-specific indication.
What are the concrete thresholds for delivery in fetal growth restriction?
The aim is to prolong pregnancy safely, provided maternal and fetal status remain stable. In early onset cases with abnormal umbilical artery AEDF, aim for 32-34 weeks, with closer surveillance if prolonged beyond 32 weeks. In REDF, aim for 30-32 weeks, and consider daily monitoring if extending beyond 30 weeks. Abnormal ductus venosus should prompt delivery between 26 and 30 weeks, individualized to the clinical picture. For late-onset fetal growth restriction and mild small for gestational age, deliver before 37 weeks if there's estimated fetal weight or abdominal circumference below the 3rd percentile, abnormal Doppler, or biophysical profile, oligohydramnios, preeclampsia, or static growth for 3 weeks after 34 weeks. For mild small for gestational age, that is to say, estimated fetal weight or abdominal circumference between 3rd and 10 centile, with normal Dopplers, consider delivery at 39 weeks, with twice-weekly surveillance. Induction is reasonable, and cesarean is only for obstetric indications.
That provides clinicians with clear guardrails. Any final take-home messages?
Absolutely. Confirm gestational age early. Differentiate early from late fetal growth restriction. Use Dopplers judiciously umbilical artery for resistance, ductus venosus for cardiac compromise, and cerebroplacental ratio for late hypoxia. Prevention also matters. Manage maternal comorbidities. Use aspirin in high-risk cases. And remember that fetal growth restriction does not always mean cesarean section.
A fantastic and thorough masterclass. Thank you for your expertise.
My pleasure.
Dear audience, I hope you found this session enriching. Don't forget to scan the barcode to access the full lecture.